It's my pleasant duty to welcome my good friend John Steinberg. So, Dr. John Steinberg is the Division Chief MedStar Health Podiatry Surgery Unit and the Program Director of the MedStar Health Podiatry Surgery Residency. And he is a professor of plastic surgery in the Georgetown University School of Medicine. John, we are very honored to have you talk to us this evening. I'm sorry, it's India, it's evening. So it's morning in the United States on a very important subject, and that's the latest in wound care. On to you, John.
Vijay, thank you very much. Thanks for the introduction. And William, great job on that discussion. And yes, I was watching very carefully in your discussion about University of Texas, because once a University of Texas, always a University of Texas. So thank you for navigating that very carefully. We have some great information to share with you this morning / this evening to our great international audience. And Vijay and your team, congratulations on putting together a great session here with a large number of attendees. We are well aware of this scenario. Each of us are tuned in right now on this morning / evening to learn how to avoid doing this surgery. Many of you on this call today are surgeons, and we certainly feel very comfortable in the operating room, are capable of doing these type of surgeries. But every time this happens at Georgetown University Hospital, I can't help but feel some sense of failure because we know that the intervention could have happened 1 month prior, 2 months prior, 6 months prior, a year prior, that would have prevented this amputation. We know that most of these are preventable with very simple measures, Vijay, as your great video just illustrated for us. So my mentor, Lawrence Harkless, loved this quote by Thomas Campbell and always shared it with us, saying, "Coming events cast their shadows before." We know this amputation is coming months or even years before it's performed. And this is where we, as the healthcare providers around the world for the diabetic foot, need to put our efforts and energies into preventing this type of amputation. In the United States, 84% of lower extremity amputations are preceded by a foot ulceration. We all know these numbers, we know these statistics. This is nothing new for anyone on the call, but it is perhaps a chance to re-energize our efforts and refocus our efforts on preventing and treating and healing diabetic foot ulceration. These lesions can and should be healed, and they need the appropriate diagnostic and treatment measures early enough so that we can heal them before it becomes an amputation. I love this pathophysiology diagram that Dr. Harkless and I have shown quite a bit in the past. And if you start at the high foot pressure zone here on the left and move forward to in the face of neuropathy, skin damage, and ulceration, we know that this bottom part of the circle with ischemia and immune compromise will face an ulceration with failure to heal, infection, and perhaps amputation. This top gray zone is where I, as a podiatrist, really like to spend most of my clinical effort time, if possible. Now, we know that oftentimes we catch patients way too late, and we are faced with infection and potential amputation that must be performed emergently. But when we can get these patients earlier on true preventive foot care, this is what gets me really excited, and I want to share some of that with you today. So here's the diabetic foot that I get most excited about. No ulcer, no amputation, patient who has history of diabetes for 15 years, moderately well controlled, has come to me for a podiatrist evaluation because their endocrinologist said, "You have diabetes and you should see a foot doctor." It's a great visit because the patient shows up and they don't even know why they're in my office. They say, "I don't have any pain. I don't have a wound on my foot. I don't know why I'm coming to the wound center at Georgetown to see you because I don't have any problems." But this is the chance for you to emphasize with the patient how important this is, how simple things turn into major complications for diabetes, and where should they come when they have a problem with their foot. Just having that memory of knowing where my clinic is and how to get a hold of our team and how to access our team can save them weeks, days, or months of access to care issues in our health system. So when we fail to act in those biomechanical situations with callus and skin trauma and skin damage, we end up with ulceration. And in this case, you can see first-ray amputation, plantar and lateral ulceration at the midfoot, that obviously is concurrent with Charcot arthropathy, in this case progressing onto full ulceration and eventual amputation. So here's another example for us with a patient that presents with acute diabetic foot infection. You can see the small ulceration that appears superficial and perhaps non-limb threatening, but the reality is that on exam, there is crepitus into the midfoot and arch. There is cellulitis extending above the ankle. This is a diabetic foot emergency and needs hospital admission and incision and drainage and immediate surgery in order to attempt limb salvage. Unfortunately, that patient refused hospital admission, refused surgical intervention, and returned 3 days later with taking oral antibiotics alone, with obviously a worsened foot infection that now requires emergent amputation. So the two slides that you see before you is the difference where on the left, we could have intervened and done a incision and drainage and saved the foot, whereas on the right, it's too late and the foot has to come off because the patient is septic and the infection is too significant and spread proximally. A matter of 3 days difference between saving a limb and performing an amputation. So key risk factors for diabetic foot, really, all of us on this call know that the diabetic foot is a great clinical challenge, but its pathophysiology is quite simple. If we can address infection, ischemia, and biomechanics, we can prevent amputation. In order to do those three simple steps, it takes a significant clinical effort and a significant concert between providers. And this is the diabetic limb salvage team. Around the world, and a great comment and check-ins from everyone on the chat, from Lebanon to Malaysia to South America to all parts of the world. We all have different teams. We all have different composures in how we deliver this care to our patients. But the key elements in that team approach and that communication oftentimes happen in a very similar manner that we're here to talk about today. We have published on this topic, and many of you have as well, about how to build a team. And for our team, one of the key factors was removing some of the hospital bureaucracy. We know that hospitals can be small government type institutions where things move slowly and management is looking at different outcomes than you are as a provider. So it's important to align our interests and align our efforts. And in doing that, we can have much better outcomes and much better efficiency of care. So an example here for you of putting the diabetic foot team together and implementing that for some of our complicated patients. Here, almost 40-year-old male with diabetes, plantar ulceration, neuropathy, 1 year duration of non-healing, who's attempted numerous wound healing modalities, including hyperbaric oxygen and grafting to this area, presents to our clinic, and we do 3 to 4 weeks worth of debridement and offloading with total contact casting. And this is as good as we can get the ulcer. So this is where one of the key elements that I want to talk about today is that we as the providers have to be alert and aware and knowledgeable of when to switch from an outpatient conservative care to a surgical management of the diabetic foot ulcer. This simple foot ulcer, if not addressed, will lead eventually to infection, osteomyelitis, and amputation. So simple foot ulcer requires simple evaluation and treatment. And in this case, the missing part was this patient had significant ankle equinus with glycosylation of the Achilles tendon, causing significant pressure to the plantar forefoot. And by doing a simple 7-minute operating room procedure, a percutaneous tendo-Achilles lengthening, we were able to address this pathology, address the pressure, well documented in the literature, high level of evidence for this procedure. And in particular, the two photos you can see on the right side of your screen, where we have the patient in a prone position and a miserably plantar flexed high pressure ulcer under the plantar midfoot and forefoot. And then after the tendo Achilles lengthening, you can see that drastic improved range of motion at the ankle from a simple 3-incision hemisection. So back to our patient, 1 week, 2 weeks, 4 weeks. So here we take a patient that was 1 year duration non-healing wound that was failing conservative care with offloading and debridement and with appropriate moist wound care and dressing. Everything was being done properly, but the missing element was biomechanics. And this is oftentimes a challenge because not everyone has access to a surgeon who can do a tendo Achilles lengthening or other mechanical balancing procedure. I would encourage you that if you are not a surgeon and you are faced with these situations where you don't have easy access to a surgeon, come spend some time with us or anyone else in your area and learn how to do a percutaneous tendo Achilles lengthening. This is a very simple procedure that can be done even in the office. We usually do this in an outpatient operating room, but it's easy to do in an office procedure room with or without local anesthesia, because these patients with neuropathy will generally not feel pain during the procedure regardless. So a very simple procedure that is easily taught and shared amongst providers. So one of our great challenges with the diabetic foot is that this all has to happen at the same time. And these procedures, including the vascular procedures and the intervention procedures for biomechanics, as well as infection management, we can't go from this left foot with threatened infection and ischemia to the beautifully healed right foot without having the entire team actively managing this patient at the same time. One of the key elements here is to tie together the inpatient and outpatient and clinical operations. So at Georgetown, one of our key models to success is that it's the same team and same providers that are managing the patient from their outpatient wound care to their inpatient hospitalization to their surgical procedures, is all tied together with the same team and same providers that are seeing the patient, rather than having handoffs and changes of team. And we feel that this has been very, very helpful for our outcomes and improving communication amongst providers to decrease the number of handoffs. I want to share in this limited time 3 brief procedures. In addition to, we just talked about the tendo Achilles lengthening. I want to talk with you real quickly about 3 procedures that really have changed the way I practice since I started working at Georgetown in 2004. Antibiotic spacers, tenotomies, and calcanectomies. So first, antibiotic spacers. Many of you already use these. Many of you have used them for a long time, but I would encourage you that based on the data that we're finding from Georgetown, you may want to even increase or expand your use in certain situations of these polymethylmethacrylate antibiotic spacers. Some of our challenging patients with diabetes that end up with osteomyelitis require bone resection. And when we resect bone, we're tempted to oftentimes choose the easy pathway, which is amputation. But we can oftentimes resect the infected bone and replace it with polymethylmethacrylate and end up with a functional foot that can be weight-bearing and worn with a shoe. So when I first started in residency and fellowship in Washington, D.C., and then in San Antonio, Texas, the dogma was that spacers are temporary, that resorbable is better because it doesn't require removal, that they all need to return for bone graft and plating and hardware infusion, and that the spacers are essentially non-functional and problematic. I would tell you that my current practice is really just about the opposite, where I believe that spacers can and oftentimes should be permanent. The preferred is polymethylmethacrylate, the standard orthopedic bone cement, rather than resorbable. You are not obligated to go back and fuse or add hardware to these joints, and the spacer can and oftentimes does provide weight-bearing support and function for biomechanics. Our evolution with spacers is here early on, using bead chains of antibiotic cement, and then eventually using some of the resorbable pellets, which were problematic with drainage, still applicable for certain sites, but not generally for me used in the diabetic foot very often, to here, where you can see the entire first metatarsal head and proximal phalanx being replaced with polymethylmethacrylate. So a clinical scenario, ulceration plantar first metatarsal with exposed first metatarsal and osteomyelitis, going to require removal of that bone, which certainly places us into a challenging scenario. With that removal of bone, we end up with a large space or deficit. We can temporarily use a spacer with our debridements and washouts, and once the cultures are clean, we're going to come back and close this wound. We do this in concert with plastic surgery and podiatric surgery, so we can replace the bone, insert some temporary fixation, and then perform a V to Y advancement flap for closure of this large defect. Here's our patient at 2 months post-op with excellent progress and excellent healing, but of course we all know that 2 months is not a reality for long-term healing success. And here's our same patient at 3 years, who now is in fact over 10 years out with excellent healing and no transfer lesions or recurrence of pressure lesion. So my second brief clinical topic that I'd like to share with you all is the FDL tenotomy. This is an old procedure. By no means is this anything new. We've been doing tenotomies for a long time, but it's a newer way to perform the tenotomy. And this is with a 18 gauge needle rather than a blade. So this is an office chair side procedure, not requiring an operating room, no delay in care, and does not require anesthesia or a significant preoperative workup. So here you can see in the face of a partial amputation, or even without a partial amputation, we know that there can be significant digital deformity or hammer toe or claw toe deformity. This oftentimes will create excess pressure to the plantar distal toe. And you can see here the resulting lesions and resulting infection that can manifest from these toe deformities. Each of these photos that you see here were actually patients that were awaiting surgical clearance in my clinic who we knew had distal toe ulcerations, and we were waiting for their cardiology and medical clearance and endocrinology clearance to go to the operating room for anesthesia and have a hammer toe correction. And during that delay, they ended up with infection and required amputation. So this is the thought process for we need to do something quicker, simpler, better that doesn't require an extensive pre-op workup as a traditional hammer toe would. So this is our traditional hammer toe correction, powerful, great procedure, oftentimes using K-wire fixation, excellent in many of our patients that require it. But for those with ulceration and those that have active pressure at the tip of their toe, this is going to take too long. It's going to be too invasive. And the vascular compromise can also be too significant. So I would tell you, I'm doing less and less traditional hammer toe correction in my patients with diabetes and more flexor tenotomy. Here is the approach for flexor digitorum longus tenotomy, usually done with a 15 blade, an 11 blade, or a beaver type blade with a plantar sulcus incision to percutaneously release the flexor tendon. I would tell you that I don't like using a blade because these incisions can tear. The skin is so tight after having been contracted for so long that when you make that incision and extend the toe, you can oftentimes end up with a tear of the plantar skin that requires extensive suturing and can place the patient at risk for infection or even amputation. So I have changed to this technique, as you can see in the video, where we use an 18 gauge needle, patient who's with a hammer toe and distal ulceration here in the clinic. This is not in the operating room, obviously. This is done as a clean procedure with a betadine prep. And watch as we insert the needle just barely through the skin, having the patient contract the toe, asking the patient to actively contract their toe down, and watch my left hand. And you'll see the release here once we go back and forth with that, using the needle as your blade so that all you have is a small hole. And there you can see the release. So very powerful procedure using the tip of an 18 gauge needle as your blade so that the only incision is an 18 gauge needle hole puncture. Excellent release, and the patient actively contracts, and you'll see an immediate response in the toe position. So here are two clinical examples from recent patients of mine. You can see a distal third toe and distal second toe ulceration. This is in the clinic. The same day that we diagnose the ulceration, we pull out the 18 gauge needle and perform the procedure. And here are these patients back at 3 weeks post-op for their ulcer check, and you can see complete healing of these mechanical-based ulcerations. I'm convinced that if we had performed the traditional route of waiting for preoperative clearance and sending these patients for their primary care evaluation, the ulcer would have progressed to infection and osteomyelitis before we were able to actually perform the surgery. And briefly, final procedure is the vertical contour calcanectomy. We all deal with heel ulcerations. These are the highest risk for amputation, highest risk for osteomyelitis, and highest risk for limb and life loss. These are miserable, difficult ulcerations that are hard to offload. Traditional approach for these was a minimalist approach with long-term antibiotics and minimal bone resection. I would tell you I practice just the opposite now of aggressive bone removal, minimize the antibiotics, and achieve primary closure with local flap. So we have published on this and have additional papers coming out now identifying how to properly select your patients for this. But the power of this surgery is that you can take a large ulcer such as this, remove the underlying calcaneal bone and infection, and use the autogenous flaps for closure, not requiring a major plastic surgery free flap procedure that places them in jeopardy of further compromise. Here you can see the logistics of performing this procedure: large, wide excision of the ulceration, wide resection of bone, progressing on to the closure with skin flaps. And you can see here our traditional approach for calcaneus was minimal resection, vertical resection, and now we recommend this vertical contour approach where you can actually resect the prominent bone and close with their own tissue without having to do a flap. So I have shared with you briefly 3 of my, I think, key clinical pearls that we should perhaps consider more often in our patients with diabetes. Again, it all comes down to infection, ischemia, and biomechanics. And Vijay, thank you and your team so much for the invitation to speak here today.
Thank you, John. It was simply wonderful. And I think we keep listening to the same procedures, but each time we listen, we learn something new.